Hopefully everyone is doing well. Go ahead and place your name and your campus in the chat if you have not done so. Check your screen name and make sure it matches how it appears on the roster. All right, we're going to call it official start time. Good evening again to everyone. If you would place your name and campus in the chat, be sure to check your screen name, ensure that it matches as well. If you need to change it and it's not sure how to do that, just let me know. We'll go ahead and walk you through that. As always, these sessions are recorded and they can be viewed by the attendance administrators. So in the event that you are not on camera, put a message in the chat to me. Don't send it out to everyone. It's why you're not on camera. If you're having to step away for an issue, restroom, or something like that, go ahead and put that in the chat because we don't want it to be that, you were not in attendance in those 15 minutes, increments will be enforced. So just make sure that you're putting why you're not in front of the camera. And also, if you have a background that's a picture of yourself, make sure that we can actually see you because we don't want any question about whether or not you were here. All right, almost the moment you all have been waiting for. We're down to week 8. And so our roadmap, our roadmap is week 12. We meet briefly. We will probably more than likely get guidance on what to do because usually in the past couple of years, campus is usually closed on that Wednesday at noon. So just put a pin in week 12. If there is an alternate day and time or several alternate dates and times, you will receive that information in the announcement section. But they do want us to meet for attendance purposes. And usually we only meet for just a brief moment, to look at statistics and just talk about a few things. Your course evaluations have been sent to your, not your Canvas mail, but your Outlook mail. So make sure that you're completing those. In the event that something does not apply, just make note of that, but please complete those. Week 11, HESIs, for sure by the end of next week, beginning of 10, you should be receiving information from your campus dean regarding, what's your next steps, what day and time is your HESI going to be. More than likely, HESIs will not be given this time of night. And I keep saying this so that you can kind of pre-plan. It might be, we don't know, but it's campus specific. And in the past, class have been on a Monday, the HES has been on a Friday. So just be looking out for those notifications. I'm not sure if your campus dean sends that to your Outlook mail or your Canvas mail. So just make sure that you're checking both so that we can, you can be, planned, rearrange things if you need to. And then that's week 11. Week 10, we will meet for HESI review. And then next week is week 9. We have that unit exam 3. So actually, officially tonight, we end our content. And so make sure for all of your courses, go back week 1 and just start chunking it up, looking back at everything. Because remember, your NCLEX, your HESIs, they're all inclusive. So, just our unit exams is just those, small windows of information. But those exams are all inclusive. So make sure that you're going back looking at everything. All right. So tonight we will make sure we cover everything. And then I think that will be it. So you do have one exam. That's next week. Then you still have 2 quizzes left. So no, the next one will open up after class tonight. It closes on Sunday. 1 exam, unit exam, 2 quizzes, and then of course the HESI and your HESI. That's it. That will be all of your things that you have left to do on this to-do list. All right, so we'll
I
move
have a quick
forward here.
question.
Mm-hmm.
Last week there was a quiz 3 that was in SurePath and everybody took, but it didn't populate in the grade book. Is that something that's going in the grade book?
Yes, it goes in the grade book. Sometimes these these platforms they malfunction. But if you complete it, it's there. It's everything is timestamped. It'll eventually get there. There was an outage I know with one of the platforms that we use, but it will be put there. Yes. Even if you complete a quiz late, it populates at zero, but eventually it rolls in your grade, eventually gets there. Are there any other questions? All righty, let's see here. So my challenge to you tonight is as we talk about all the different concepts, I'm going to pause for a moment and just let you kind of think through and do some jot noting on your own note cards or notebook about what that concept is and what it encompasses. And so the concepts that when you look down at your paper and you don't have anything there, it's blank. That's the concept you're going to need to go back and start with first. Now we'll call out some page numbers, and I'm going to just follow our note taking guide, and then, but nevertheless, you do have your required readings. You don't have to really worry about the page numbers if you don't want to, because you do have the required readings, the PowerPoints, and all of that information is in your course shell. Now, I create my own little PowerPoints from that and create and put some little designs to it, but nevertheless, it's still the same information. All right, so ethics in public and community health nursing practice. So when we say ethics, what just comes to your mind? Like one word, put it in chat. What's one word that comes to mind? Not that you're trying to define it or anything, but when you hit the word ethics, what pops up? What do you think of? Just share that out with everyone. I'll give you just a minute to do that. Ethics. What comes to mind? Let's see, a little minute have been and went by before I can find this little clock here. So ethics, just populate that. What comes to mind? What do you think of? Someone says morals, honesty. So everyone should be placing a word or a phrase in the chat when you hear ethics. Not that you're trying to define it, but you could be. What comes to mind? Right? What is right? What is wrong? Great. Treating people fairly, code of conduct, how to treat others. Great. We do talk about a few principles. There are a bunch of them out there, those ethical principles, but we do talk about beneficence and then the non-malfeasance. So is what we're doing, I'm trying to share on screen here, is what we're going to do, is it going to benefit the patient? Is it beneficial? Being fair, respectful. Okay, great. Thank you. Slideshow. Put us over here on the side. Make sure this is my first one. It's trying to be fancy. My little PowerPoint going the wrong way. Okay, there we go. All right. So the this all this information comes from chapter 6, which I have it noted as pages like 104 through 111. Nevertheless, it's on your required reading list. So the ethical principles of beneficence and non-malfeasance. There are others, but usually these two, we're all the time thinking about like, okay, is this intervention going to do this patient any good? Am I going to cause this patient harm? And then the patients are thinking the same thing. Hey, I know, this is my nurse. I know this is my healthcare provider, but do they really have my best interest at heart? Is this intervention, the things that they're going to be doing, is it going to be beneficial to me? So they're thinking about it as well. So do need to know these two ethical principles here, and they do come back. They trace these back, all those principles back to the Hippocratic Oath for healthcare professionals, and provides a framework for patients and clinicians relationships. So this kind of guides, and all of those things that you put in the chat, those are spot on. So ethical dilemmas are human dilemmas and puzzling moral problems in which a person, a group, or community can envision morally justified reasons for both taking or not taking a certain course of action. So if you look in the chat, some people wrote what is right, what's wrong, being honest. Let's see what did you all put. Stop for just a moment. And compare it to what we have there, protecting confidentiality, things that are good versus things that are bad, how we are treating people. All right. So ethical dilemmas, while we go in and our intentions are pure to do everything correct, there's sometimes going to be a dilemma. There's going to be something that comes up. And a lot of times it's just because the other party or person might not be aware of what's supposed to be taking place. If there are questions, they may not know what that procedure is to get questions answered or either to just even ask their questions. So that's why it's so important to upfront establish those therapeutic relationships. We want to be assertive, not aggressive, not even non-passive. We want to make sure that we're letting our patients know, hey, the nurse will be in, we'll change your dressing. These are just some examples. Your wound dressing every 2 hours or once a shift. The expectation is that, your meals would be served at these hours. In the event that you eat less than whatever the percentage is that's approved by that facility, we have to offer you an alternate or some type of supplement. So a lot of these dilemmas come from patients either not knowing or being misinformed, having a wrong understanding about what should have happened or what should be taking place. So when we talk about feminists in ethics, if you had to come up with one word for feminist ethics, what would that one word be? And someone just come off mute and tell me, what would that one word be? If you get to narrow it all down. Equity, equality. While yes, we're saying mostly females, but the whole premise is that we should be treated equal and there should be equity. So feminist ethics is pertinent to public health because it recognizes the role of the political and social structures in health. Those roles are in there. Issues of equity present major challenges in public health. Feminists advocate economic, social, and political equity, all things just being equal. Okay. Ethical advocating, respecting, and collaborating. Remember, it's not a one-man show. It's going to take that collaboration, those partnerships with the patient and the healthcare providers. According, and someone put privacy in the chat when we were talking about when we asked the first question. So according to HIPAA, the Health Insurance Portability Accountability Act, we must keep things private. So we have to be cognizant of when we're talking and discussing when the healthcare provider is there. Even at the nursing station, the way some buildings are made, it might be near the elevator. So we have to just be careful when we're giving information out and where we're just talking amongst ourselves. And especially if a relative asks to view the information, we have to get permission. We have to get that written permission from that patient. Even if they come up and ask, well, hey, can you tell me what the doctor said about the patient? And so, you want to get permission from that patient to be able to tell them that. Otherwise, and all this, of course, I made these slides, so that was blank. I thought I took it out. So we can always refer that visitor, that family member, even if it's a spouse, back to that patient because we don't want to violate that HIPAA. Okay. So for chapter 7, we're going to be looking at cultural of populations. So my notes, I have make sure we look at pages 120 through 125. Of course, you have the whole chapter there, but just make sure that you are referring to those pages, and we'll go through this information too. So culture, what is culture? It's a set of beliefs, values, and assumptions about life that is widely held among a group of people and that is transmitted across generations. So if we were trying to explain to a layperson what culture is, what would we tell them that it is? I know we have this definition on the screen, but just paraphrase it or narrow it down. Let me hear from two people. What would you say? Define culture. Culture. Define culture. How do we become culturally competent nurses? Is it important when we're providing care? Is it important when you're receiving care and when you're on the other end as the patient? So give y'all a moment to get your thoughts together. But if someone would, just to paraphrase what culture is.
I would say it's like a way, like a group of people, how they live their life, specifically, whether it be religious beliefs, um, just like how things that they eat, just different things like that.
It can also be their death practices. How
Costume.
Was there a third person?
Costumes.
Okay. Yes, and all of that is correct. Great. Thank you all for sharing. So again, create those therapeutic relationships. Find out what, as much as we can about our patients so that, we are not so that we are providing that culturally competent care. We should know their preferences, their values and their needs and everything. Because think about if we were on the other end of it and we were the patient and our culture, our norms, what we eat, what we don't eat, that's important to us. And so it may make the difference between whether or not I eat a meal or not eat a meal. But if we already know these things, or we bring the dietitian in, for example, to talk to the patient, we can be proactive. And that lessens the chance of this person not eating, having a poor pill intake. So race is a biological variation within populations groups and based on physical markers derived from genetic ancestry, such as skin color, physical features, and hair texture. So in past-oriented cultures, time is viewed as being more flexible than in present-oriented culture. So if someone's in past-oriented culture, it's like, hey, they're just kind of hanging out. They're really not worried about the future, not even thinking about it. And depends on what, whether or not they're in past oriented or present, is going to shape how they make their next steps or their next decisions. Nurses socialized in the Western culture may view time as money and equate punctuality with goodness and being responsible. So if the person is on time, that means, hey, they're responsible and they're good. Working with clients who have a different perception of time than the nurse, it can be problematic. So if the patient, if they, they're not saying that being on time is a bad thing, but it's just not at the top of their list. So then, we're trying to get our patients moved through, and this patient, they just walk, they walks in at 10 minutes after, 15 minutes after, there's no call to say, hey, I'm running late or anything like that, then there could be a kaboom. But then if we already know up front that this patient, time is really not an issue with them, we can go ahead and just have that conversation. Hey, we want to keep people on schedule. Would it be best if we schedule at the beginning of the day, the end of the day? Is today a good day? And so we just go from there so that things don't become problematic. Nurses should clarify the client's perceptions to avoid misunderstandings. Like we said early on, a lot of times when we have these dilemmas, it's just that people have a different idea, understanding of what should be taking place. And not to say that what they're thinking is realistic, but we want to clarify what their perceptions are. What are your expectations? What do you think is going to happen today while you're here in the urgent care? What do you think is going to happen while you're here at the long-term care facility or when you come in to get this procedure done? And so it is not realistic to expect clients to change their behavior and adapt to the nurse's schedule, though. Even though we're still, we have the conversations and we're being proactive. They may or may not change their behavior. But with us knowing that we can, if we think that it's better to schedule the person, on a different day or a different time, be the first patient or the last patient, then we can do that. That's just one example. So someone read this for me.
Social detriments of health are the circumstances in which all people are born, grow, live, work, and age that shape health.
So those social determinants of health, we have to think about, step back in the big picture. Okay, where does this person live? You know, if the clinic is on this side of town and the person lives on the other side of town, and then there's no public transportation, this person doesn't have transportation themselves. You know, do this person works? Our hours are we only have late appointments on Wednesdays. You know, the scenarios can go on and on, but we should, because the social determinants of health, they are important to consider, and it does shape a person's health. I think it was, I don't know if it was this class or not, we were doing a windshield survey, and we'll talk about that here in a moment. Things should be popping up when I mention that term. And we were just trying to assess the level of physical activity in the community. So while we were, checking the community out walking around in the car, talking to the people and everything, we found out that the physical activity was low. And then it was like, well, okay, well, what made it that way? Seemed like a nice neighborhood. Didn't seem like, any safety was an issue. Well, the sidewalks, the places that they had to walk were in ill repair. So it wasn't safe for them to be out walking. So and of course, they didn't have a park area, but they did have sidewalks. But the sidewalks, like I said, were in ill repair, and would be at risk of falling. So they just, decided physical activity wasn't an issue because they couldn't do anything about the sidewalks. Yes, they probably could have went to, the park area or somewhat to the gym and all those places. But what if that interfered with their work schedule? So yes, it is important. It does shape our health. Okay, so another example about those social determinants of health, we have, let's say, work. Person is working, but then they make enough money. They make too much money to qualify for a certain insurance type, but then they don't make enough to have to subscribe to the insurance on their own. And so what does that do for that person's health? What do you mean? Well, if they don't subscribe to insurance, when they go to the doctor, they're going to have to pay out of pocket because they don't subscribe to insurance. And so more than likely, have you ever seen a doctor's bill when you do have the insurance? So think about if a person doesn't. So what do you think it's going to do about their preventative exams? Even if they have something going on with them, you think they're going to put it off, or are they going to go on in and pay that fee? So all of these things do shape a person's health. All right, so someone read this for us. Let's over here.
Documented immigrants are known as lawful permanent residents, refugees, and persons seeking asylum, non-immigrants. These are people admitted to the United States for a limited duration for a special or specified purpose. Undocumented immigrants or undocumented or legal aliens.
Okay, so
sorry, I'm losing my voice.
Oh, that's fine. That's fine. Thank you though for reading. So these are the 4 categories of foreign born. So they fall in one of those categories. Even though non-citizens are as likely, let me start over. Even though non-citizens are as likely as citizens to work, so that means that they're going to work just like the people that are citizens. More than likely, they may be in jobs that do not provide that health coverage for employees because the health insurance that they have might not cover because of their status. So even though they're working, when we're doing community work, we want to consider hey, we want to make sure that we've identified all the different resources because the people that live in this work and live in this community might not have health insurance. And then they may have health insurance, but it might not be enough to cover the services and things that they need to manage their chronic disease process. So we just want to keep that in mind. So it's not automatic that everyone has health insurance. So community partnerships focus on active participation by community leaders, businesses, organizations to develop programs with healthcare professionals. These programs have a larger goal of collaboration to achieve an outcome that benefits community members. And so an example would be a community partnering with an organization that provides wellness exams. And so while the community might not pay for them to come in and get the wellness exams completed, they do have to like put a stamp of approval. So they have to allow you to come into your space. So it may not be a direct cost to the community, but they do have to say, hey, it's okay for them to come in. But then the reward or the upside is the people that live in the community are getting these wellness exams without even having to really take off work because you just pop up throughout the community. Don't have to have an appointment, and there is no fee. As a matter of fact, they compensate you by in the event that it's identified that you need to increase your physical activity. In the event that it's identified that you need to, you say, hey, I want more access to fresh fruits and vegetables. There's a resource that is there and available that can route you to the YMCA, route you to the local gym, that can sponsor a certain amount of fresh fruits and vegetables from the mobile market, the farmers market, and so forth and so forth. But it does take this participation and this collaboration. It also takes the community members coming out to take advantage of it. So, and we talked about it. I think I don't know, was this class or not, where they had the Medicaid expansion. So that's why you'll go to some states and some things are available, and then some things are not in other states. So it's good that these businesses and organizations have created these alternate routes to still take care of yourself and see about what's going on with you. All right, so here we go. Someone else volunteer read this slide.
A business that provides low-cost snacks through an after-school program is an example of a community partnership. A city creating a new park, a hospital providing vaccination clinics, and recreational center offering cooking classes are passive partnerships.
Okay, so the passive is on a larger scale. If you the example they gave about providing the snacks to the child, so that's like a one-to-one thing. But having the park, like in one area, they actually renovated the park. The park had a fish pond in it. I have never seen anything like that, but they actually, you think about renovating a home or something, they renovated the pond, and it was grown up. You didn't even realize it was a pond there. But nevertheless, they renovated the pond so people can fish there. The park is back up and running. And so people can go there and walk, they can walk themselves, take families there. So that's a passive partnership. But when you're directly working one-on-one with someone, these children that are in the school, have provided that after school snack for them or before the school snack for them. Another thing that we did was on Fridays or at the end of the week, sometimes you had that longer weekend. We did it, I don't want to say every week, but maybe like twice a month. But on that Friday, specifically if the children or the parents say, hey, we need the bag. And so they would leave school with a bag full of, different nutritious snacks. And that's another example of that community partnership because we're working directly one-on-one with that excuse me, patient or that school-age child or that family member. So during a community assessment, the nurse will perform data gathering. We kind of talked about this last week. Data gathering and data generation. So data generation is a process of identifying data that does not exist, but it is developed through interactions within the community. So you get this information from having conversations like we got out, we were doing the windshield survey, we're talking to the community, and our whole focus was to find out, hey, what is the physical activity level in this community? So it wasn't written anywhere, documenting anywhere that the sidewalks were bad or anything, but it was just, it was what it was. And they told us that. And so we could verify that, but it wasn't necessarily written anywhere. It wasn't at the mayor's office or anything like that. Now, do they know? Did they know? I'm not sure. But this is information that is generated through interactions, through talking to the community members. We may can even give them a survey. The survey can be electronic, it could be an in-person survey, but nevertheless, we're gathering information. And data generation include information about the community's values, beliefs, and social norms. They wanted to walk. They wanted to be out on a nice sunny day or a cool evening, but they couldn't because they said it wasn't safe. Not so such that it was crime, but they would probably fall and injure themselves. And then the other option was walking in the highway, and they didn't want to do that. So data gathering is the process of collecting information that exists, such as the age of residence. So these would come from like your census and things like that, racial distribution and health organizations. All right, so when we say windshield survey, then someone come off mute and tell me what's your understanding of a windshield survey? What's happening?
You're looking at communities, you're driving around looking at like the buildings, playgrounds, just different areas of the city.
Right, thank you. So a windshield survey is a method of collecting information, data about the community by observing community through a car or riding on public transportation. Nevertheless, you're in that community, seeing what's there, what's not there. To conduct the windshield survey, the nurse would need to understand the community's boundaries to ensure that the community is adequately observed. Making sure, like, for example, it could be, on don't come on a Wednesday because, on Wednesdays, everybody's at the ballpark with their children, or on Sundays, for the most part, this community, everybody is at a place of faith and, or, you can ride through the neighborhood, you don't see many people out. So, and we're doing this to bring a community resource to the community. So if we know Wednesdays and Sundays is not a good day, then those are 2 days we more than likely would not have our community event. We had a mobile unit and we were just taking it to different communities, and they told us, hey, on Fridays, don't worry, no, don't even call us. We're not coming for those appointments. So the community said it, and we tried it. And sure enough, the yield was very, very low. But they had already told us, hey, we have other things to do on Fridays. So if you come Monday through Thursday, you got our 100% backing. We will show up in numbers. And so you do gather this information by interacting with them. The population size, socioeconomic qualities, and governmental structures would be observed also during the survey. So we have a needs assessment, surveying clients' knowledge of resources. Are they even aware of the resources that are there? How do you utilize them? Because some of these things, the resources are there, but they're kind of like a spider web. You just have to figure out this, and you do this, and then you still don't have access to the resource. So do they even know the resource exists? And if they do, they know how to actually source it, access it. So identifying resource eligibility criteria, that's another one. The resource is available, but it might be only available for males between the age of 40 and 44. And that's just something that just came to mind. But if you don't meet the eligibility criteria, then you cannot, utilize that resource. So what do? We identify other resources and see if there are any others there. You might have to also identify resources that are outside the community, but you do want to start inside because you don't want that to be a barrier that the person has to go outside to travel, but sometimes that's how it is, especially if we're talking about rural areas. When completing a community assessment, the nurse will include community systems categories found within that community, which includes politics, education, recreation, economics, and religion. We have to think about all of those categories because all of those things are important to the patient, the community member. So when we're talking about the community, what comes to mind? Three things should come to mind. When we're saying community, what are we referring to? In the chat, put those three things there in the chat. We'll give you a minute. When we're talking about community, what are those three things that we're referring to? Trying to get the little timer up. Okay. In the chat, what are those three things? Uh-oh. What are those three things? Okay. You're saying the people. Got it. Let's see. What are those three things, you are? All right. Keep it going. So refers to the dimensions of the place, the people or the person, and then the function. When measuring the dimension of people, the community health nurse would access data sources from the census data, the tourist bureau, civic groups, and churches, and things that are like that. Libraries, police stations, welfare agencies, and the state departments would be data sources to measure the functions dimensions. The dimension of the place would be measured with data sources like maps, newspapers, and local housing, the local housing office. So timer off here. Place, people or person, and then the function. Okay, and so that was it for those pages. Now we're going to transition onto case management. And from my notes, of course, you want to read the whole chapter, but for sure, the only page that I have referenced is page 273. But you're still responsible for reading that whole chapter, but for sure, page 273. So case management, in contrast to care management, involves activities implemented with individual clients in the system. The case managers builds on basic functions of traditional nurses' roles and adapt new competencies for managing the transition from one part of the system to another or to that patient's home. So we had that case manager. Anyone familiar with the case manager? If you are rotated with the case manager and on your current job, you may be on that case management team. Anyone want to share your experience with identifying all those different resources? And that's go ahead.
I work in an ER, so a lot of our case managers just help with resources, specifically for like BHU patients, placement of them going to other facilities. Sometimes it's helpful for them to get rides for people after they're discharged from the hospital. They just have a lot of resources and outreach to other programs and businesses that can help people that are in need.
Exactly. Just a wealth of information. And then even if the person does have insurance, if they're going to go to for example, being discharged from the hospital and they're going to a long-term care facility or another facility, there are certain facilities that accept certain insurances, and if you do go, then some insurances say, hey, you can only stay in this type facility for 5 days, but then the doctor's saying you need to stay for 20 days. And so they have to think through all of that and reach out to those facilities. They have to know the insurance status and which facilities to or not to send the patient to. Yes, it's a lot of moving parts with that case management. Although the activities in case management may differ among providers and clients, the goals are as follows. We want to provide that individualized care you want for each client. We want to promote quality services, reduce institutional care while maintaining quality processes and satisfactory outcomes. We want the client to be as independent as possible. We want to not use resources that are not needed because we don't want to waste, and also to manage resource use through protocols, evidence-based decision making. So they usually have some algorithms, and just like the example that I gave, we don't want to send the patient to this facility when we know this facility is not going to accept their insurance. And so if this patient needs rehab, they go to this facility, they're not going to receive rehab because the insurance is not going to pay for it at that facility. So it takes thinking through all of that. They have some algorithms out there, some protocols, and nevertheless, can't get away from individualized and evidence-based decision making. We're not just haphazardly pulling things out of the air. The evidence suggests that this is what we should be doing. Okay, so limits availability of healthcare providers can be a challenge. They're saying we have nurses shortage, especially healthcare providers that are specialty. Endocrinology is one. There's another, not dentist. It's not dentist, but I remember endocrinologists is like people are having a hard time with that. The doctors that, oh, it's leaving my head, that deal with vascular disease processes, those are kind of rare too. So you do see even urologists, that's another one that we're seeing. They're like coming to areas like maybe twice a month because they know that the reach is they know there's a limited number of them in most areas. And so case managers must navigate the resource. They have to think about the constraints, the barriers, and all of that, and still provide that best care, that timely best care that they can. We want to collaborate with those in making sure that we're communicating. We want to communicate what we're planning across all disciplines, because it's going to take that in order to come up with that individualized care plan, best care plan for that patient. A lot of moving parts. So we scope of practice for the RN and LPN. I think on each exam you all do see some examples. So we do know that the unlicensed personnel can provide, the activities of daily living, bathing. They can obtain vital signs and things like that, but they cannot interpret. They're not administering medications. We as LPNs, we can reinforce education, but we don't do that initial teaching. And so even with the assessment, we can do an assessment, but we don't do that comprehensive assessment. The RNs do that. All right, so we're moving right along here. So disaster management. I want to say probably about 2 or 3 years ago, it seems like trains were just derailing. I don't know if it was what was going on. But we have natural disasters, man-made disasters. And I'm just looking at my page numbers I have for this one. So, of course, it's chapter 16. You want to read the entire chapter, but we do have the information. I have the information on the slide here. But the how to be Red Cross ready is on page 292. It's there, but I do have the information on the slide. I tried to pull as much as I could to the slides. Okay, so when a federal emergency has been declared, the NRF may provide specific needs to the community. The role of the NRF is to support the community that's experiencing the disaster. So how do they support the community? With transportation, housing, temporary housing, medical resources, search and rescue, and firefighting. Just think, I do have some videos. I don't know if we get a chance to watch them, where like you see like a community disaster has come through from maybe like a weather event, and you do see like all the people coming together, all the different moving parts, and trying to, keep people safe, and provide that shelter, that bottom layer at Maslow's hierarchy of needs. But yeah, so the NRF supports the community by providing temporary housing, transportation, search and rescue. Each disaster phase has a distinct purpose. Preparedness focuses on planning and drills. How many of you all, they come in and you come in, I know like in some facilities, how they plan for the fire drill, they'll have like a little box that says, the word fire written on it. And you have to actually go through the motions and all of that. They even have, what do they call them? Well, they have like not a statewide, but like a citywide drill where they said something has happened, and they'll have, and everybody, all the fire department, the hospital, everyone has to like get in that mode and practice what they would actually do. So each disaster phase has a distinct purpose. So preparedness, focusing on planning and drills. Response prioritizes immediate triage and life-saving care. And then the last one is recovery. It restores community function and provides long-term supplements. Levels of prevention. Remember, all our exams have been heavy on that, you all. So just take a moment. We'll give you a moment to kind of think about what are those 3 levels, and then what is each level? What would be an example? Like, what is with primary? What are we doing? With secondary, what's actually happening? And just think about all the different scenarios that follow from it. And then tertiary, what's happening? So we got primary, secondary, and tertiary. So primary prevention means keeping the crisis from occurring. And so that's education about the sky's the limit. We want to prevent motor vehicle accidents. We want to prevent heat injuries. We want to prevent cold injuries. We want to prevent, so give me another example with primary. We're trying to prevent primary prevention. Someone give me an example of primary prevention.
Vaccination.
Okay. Secondary focuses on decreasing the intensity and the duration of a crisis. So we are trying to screen, detect, determine. So a crisis has happened. We may be on that red cross team where we're going knocking on doors to see how each person is in that neighborhood. We're screening. We're trying to detect, determine. Hey, are the people that live in this home, are they okay? So that's that screening process. We're detecting. We're trying to determine, trying to see if there's an injury, a disease process, or something going on. And with tertiary prevention, it involves reduction of the amount and degree of the disability, injury, and damage after a crisis. Activities that are carried out when evaluation indicates needed improvement. So something has happened. There's been a tornado. And so we're knocking on the doors. We have screened. First of all, I'm going to back up. We have a community event. We've done commercials. We did radio announcements. We was telling people to get weather aware. Get your kids ready. Get your kids ready. Okay. A storm came. So now we're out knocking on doors to checking to see if people are okay. So we're screening. We're trying to detect, determine. And then for tertiary, we have identified the person that lives at 501 Apple Street. They have they're without power. They have a broken leg. Something has happened, so we need intervention. So that's tertiary. So we said disasters are labeled as natural or man-made. Natural disasters are events that occur naturally, such as earthquakes, communicable disease epidemics, droughts, and hurricanes. So man-made disasters are events that are directly human created, such as pollution, like these industries, warfare, fires, and water supply contamination. So we have your facilities. Have you what color is your MSDS book? And most of the ones I've seen, they're yellow. Y'all, if you all pay attention to this book that they have located at the nurse's station or along the hallway, what's in that book? All the things about every chemical that's inside of that facility that's being used. So it provides information about the chemicals. In the event that something happens, you can go to that book and find out all you need to know about that chemical, MSDS. And I'm not saying the books can't be any other color, but for the most part, I've seen them in facilities, they're yellow. Disaster management, and it is a requirement that they be there. But if they have a chemical that's the environmental services are using to clean with, if there's a chemical, if it's the hospital that the OR team is using, they have to have a sheet in that book about the chemical. Disaster management includes 4 stages: prevention, preparedness, response, and recovery. All hazards mitigation is an emergency management term for reducing risks to people and property from natural hazards before they actually occur. So we can reduce the risk, decrease the chances of something happening. We want to do that. How to be Red Cross ready. I think that's that chart I was telling you all that was on the page that I said it was on. 292, but nevertheless, we have the information right here though. Just gonna stop sharing for just a moment. Any questions about the content that we went over thus far? Okay. So get your kits ready. Consider the following when assembling or restocking the kit. We want to tell them that they need at least 3 days of non-perishable food and water. That equates to 1 gallon per person per day. And that means drinking and for hygiene purposes. Battery powered or hand crank radio. Flashlight and extra batteries. First aid kit, medications, medical items, all those things that they're going to need, that they would need on a daily basis anyways. We need some of those things in there. And then copies of all important documents. For those of us that wear glasses, we'll need an extra pair just in case something happens to the ones that we have, especially if you need them, to actually, move around and everything. Make a plan. Talk with everybody that's in the household. The person needs to know, what to do in the event that, the main person is not there. Who should we be contacting? I've seen at a lot of facilities, not a lot of facilities, but a lot of homes here lately, like they're at their exit, they're at their doors. They have like a little sign. It's a nice little lady the other day. She actually had a nice little picture frame. And I was looking because the picture frame was attractive, but what she had in there was a list of people. And she says, in the event that she cannot speak for herself, these are the people that they need to, like we were to come into her house and find her incapacitated or something. These are the people that we need to be calling. So she had that. It was a nice little picture frame there. So talk to the household members. Who, do they know what to do? Do they even know where the kids are? And don't forget your pets. So in addition to the items in the how-to box, include these items: manual can opener, list of medications, a list of allergies, doctor's names, candles, matches, sanitation supplies, toilet paper, soap, plastic garbage bags. I like Ziploc bags. Special items for infants, older adults, pet supplies, birth certificates, insurance policies, store documents in a waterproof container. Okay. So for targeted competency, safety educating. Let's see what I have here. So we still want to create that plan and look at our checklist. We want to post emergency phone numbers next to telephones. Teach everyone how and when to call 911. Determine when and how to turn off the water, gas, and electricity using those main switches. Okay, we want to install and maintain smoke detectors. Red Cross has a program where they come in and they install them. And I think that's like a nationwide thing, that service that they actually provide. Acquire first aid and CPR certification. A thing that they're pushing now is hands-only CPR. And Red Cross is one of those places too that is providing those trainings for laypersons, because studies have shown that that the chest compressions, if someone does that, that person has a great chance of surviving. So there was an initiative statewide where they were trying to get, because people kind of got afraid of, the mouth to mouth and what do I do, hand placement and counting and switching out and all that stuff. So they went for the hands-only CPR. And so we have done trainings all over at, walks at the church service, after church, before church, at the YMCA, all different places, just so that people can just at least be familiar with what to do, in the event that, someone needs that service. So practice and maintain the plan. When teaching a family how to prepare a kit for disaster, nurse should instruct the family to stock enough food, we said, for 3 days. Review the kit every 6 months. That's to make sure that we don't have anything that's expired in there. And make sure we haven't used the things out of the kit too. Because that's what kind of happens on our end. Like, oh, let me go get this out of here. We know where that is. So components of the emergency operation plan: a plan for drills, a deactivation response, and a plan for security. All right, so now we're going to actually look at public health and surveillance. So what pages did I know? This is chapter 17. So of course the entire chapter, but I have pages 305, 306, and 310. Those are the ones I made note of. Okay. So observation and surveillance is the process of ongoing systematic collection, analysis, interpretation, and dissemination of health data used to monitor disease trends. Collect the information. What is it telling us? We analyze it, look at it. Okay, what do we need to do to prevent more occurrences from happening? So the purpose of surveillance is to assess the public health status. Are we good or do we have an outbreak? Identify trends of disease patterns. So as that school nurse, you want to be identifying, well, hey, it's 9 o'clock and I've had 10 babies that have come and they have the stomach virus. Okay, well, what has happened? Did they all ride the same bus? Did they all eat breakfast in the cafeteria? Did they all get the same snack out of the snack machine? So you start to think about what's going on. And then if it's a certain percentage of children out of the certain total number, then a lot of times what they've done is they shut down the schools for that cleaning or just to see what's really happening. So the purpose of the surveillance is to decrease morbidity and mortality by preventing or controlling the spread of the disease. So yes, we have to step back and look like, wait a minute, what's really going on? And so that was an example about being the school nurse. And you're collecting the data anyways, but you need to analyze it. Okay, what is really going on? Is it just one or two that's coming in with the runny nose, or, do we have a flu outbreak? Same thing, I think, all the children, everybody, for the most part, is back in school now. And so someone mentioned, there was a lot of colds or sore throats. Everybody's getting back together, and so you will see that after like Christmas breaks, along summer breaks. So disease surveillance is the ongoing systematic collection, analysis, interpretation, and dissemination of that health data for use in public health. So you're all the time looking at numbers, collecting information. So surveillance means for nurses to monitor disease trends in order to reduce morbidity and mortality and to improve health. We don't want anyone passing away. We don't want anyone to actually end up with the strep or the flu if we can prevent it. So we have to be keeping up and thinking all the time, okay, is this the only person or is this a trend? Okay, disease surveillance is the ongoing, same thing, collection. Surveillance provides a means for nurses to monitor disease trends in order to reduce, again, their morbidity, mortality, and to improve overall health. So no matter what the setting, school nurse, if you're working at that industry, they're making, I don't know, shoes there, and you notice several people are coming to, the nurse's station because they're having headaches or they're having injuries. What is really going on? We have to step back and look at that data. So the purpose of the surveillance: to assess public health status, respond to unusual disease spread and terrorism. But overall, it is to improve the health. Surveillance systems in use today are defined as passive, active, sentinel, and special. So we're going to talk about those. So passive systems, case reports are sent to the local health departments by healthcare providers, or laboratory reports of disease occurrences are sent to the local health department. So you might have that task in that facility to be the one that calls it in or submit the information to the health departments. Someone read this right here about active systems. Next couple of slides.
Active system. The nurse and the employee of the health department may begin a search for cases through contacts with local healthcare providers and healthcare agencies.
So on this one, they're actually calling the doctor's offices. Passive, they're just waiting on the doctor's offices, the long-term care facility to just call them to report. But for example, the CDC collects this information. They say, hey, you all, we've been seeing a rise in whatever, in this place. So what they'll try to do with the active system, they'll go ahead and just start calling. Hey, have you all had anyone in with these signs and symptoms? And then that also puts them on alert so that we can start looking at if they do come in to make sure that we actually report that. So someone read this one for us for the Sentinel system. What happens there?
In the Sentinel system, trends in commonly occurring diseases or key health indicators are monitored.
Okay. They're just monitoring it. Special systems are developed for collecting particular types of data and may be a combination of all active, passive, and Sentinel. All right, so patterns of occurrence can be identified when investigating a disease or event. These patterns are used to define the boundaries of the problem. Hey, is it everyone that went to that restaurant on Monday at noon? Because the people before that went to that restaurant prior to noon. Is it everyone that ate breakfast that morning? The examples go on and on. A common source outbreak refers to a group exposed to a common noxious influence, such as the release of a noxious gas. In a point source outbreak, all persons exposed become ill at the same time during that one incubation period. Surveillance systems are essential to protecting the public's health by assisting with early detection and disease and implementing interventions to reduce mortality and morbidity. So these systems are in place and they are important because you really don't know that they're behind the scenes keeping up with this information until you see that commercial or you receive that text message that says, hey, school is closed today for deep cleaning. That's just an example. But they're keeping up with that information. And or if the CDC comes to town because there's a high incidence of, for example, tuberculosis in the area. And so they'll come in because remember with the passive system, the doctor's office, everybody's calling this information in to report it. So once those number gets to be a certain number, they want to prevent the disease process from spreading. So they've come in and one area, they wanted people to get tested. And then, they wanted you to come back and get retested because they were saying that it was just a high number, an unusual number of active cases. So the passive system relies on healthcare providers to report an existing case. So we just said that. Passive surveillance relies on routine reporting by providers. And that might be one task that you'll have at the facility that you decide to work at, where you actually call this in. Anyone already? This is a task for you that you call it in the event that there's a reportable disease in your area. Anyone familiar with that? So COVID was one that stands out. If people tested positive, you had to call it in. And then prior to that, you had to gather all this information. Where have you been? Did you go to church? Did you go to, to the grocery store? You did. How many people did you come in contact with? And when you call it in or scanned it in, all this information had to be submitted. So we say in the active systems, the health department searches for cases by actively contacting the providers. We said that. I must have repeated that slide. I think I repeated this one too. So the syndromic system focuses on real-time data collection using an automated data entry system. So the automated surveillance improves the speed and completeness of the reporting, just kind of speeds things up. So it's not waiting on a person to actually compute everything. Okay. So let's see, chapter 18. I think we just have two more chapters and we're good with our time. We're going to push our break toward the end. So we make sure we go over everything, but we're almost there though. Program management. So program planning begins with a needs assessment. So what pages do I have here? I've referenced page 317. Of course, the whole chapter is your required reading, but for sure, page 317. Program planning begins with a needs assessment to identify the problem, population needs, and then the available resources. Without an accurate assessment, interventions might not meet the community's priority. You may just be doing something that's not even needed. Okay, that was all we had for that one. So chapter 19, let's see what page is 332. I think reference one page here. I'm talking about the QI, the QA. Yes, that was it. And then I'm going to toggle and let you look at that chart too. All right, so here we go. Primary prevention begins with a community approach that incorporates strategies from criminal justice, education, and public health to prevent. We're providing information to prevent. Some communities have used the following. This is an example. School-based curricula that teach children and youth how to cope with anger, stress, frustration, teach them communication skills because we're trying to prevent acts of violence. So these are examples of primary preventions because we're trying to prevent violence. So family programs that teach parents how to deal with their children more effectively, preschool programs to develop intellectual and social skill programs, and then public education programs that can educate communities about different forms of violence and ways to help and intervene. Prevent, that's primary. So the term services applies to a wide range of health delivery institutions. Of particular interest to the public health are the following. The question of access, can I get there? Is it even available for me? A well-prepared workforce, people that work there, do they know what to do? Improvement in the status of the population's health. So we have access, we can get there, the people know what to do, and they're taking care of the patients. So patients are satisfied, the people's health has improved. Okay, someone read this slide for me.
Continuous quality improvement is the structured approach to improving performance focused on preventing and identifying process improvement opportunities. Quality assurance focuses on accountability by detecting errors, fixing blame, and performing a post-event investigation.
So anyone here actually work on these teams in your facility, the QI team or the QA team? And so this is things that facilities they do so that they can fine tune their processes, making sure that the procedures and things they have in place are correct and are the best at that moment in time. So QA, they look for things that are wrong and they try to fix it. They identify these things. And this is just the in-house thing that they do, but know that these are teams that you can actually work on and or lead. When developing a quality improvement program to improve client satisfaction of tangible service, the program should focus on ensuring the staff is aware of the customer service. Staff needs to be aware of what's going on. Hey, this is what we're doing to try to improve processes. The goals of QI are on a continuum of quality, and in public health, they are number one, to continuously improve the timeliness, the effectiveness, the safety, and the responses. And then number two, to optimize internal resources to improve the health of the community, which in it's going to be client by client or patient by case anyways. So we want to evaluate our QI programs. So the first phase is the structure phase. So during this phase, the nurse will determine if the philosophy and objectives align with the job description and the organization's their standards. So we have structure phase, then we have the process phase. What happens on the process phase? The nurse will evaluate the quality of care being cared by reviewing the nurse's care procedures and identifying professional procedures. And then we have the last phase is the outcome phase. And this is where we're evaluating the results. And we're measuring those health indicators. All right, so I need help from someone else. Read this slide for me. Any questions so far? Because we about narrowed down everything. Any questions? Okay. Hearing none, would someone read this slide?
Keystones of evidence-based practice guidelines arise from client concerns, clinical experience, best practices, and clinical data and research. Guidelines provide research-based evidence for interventions and promote improved health outcomes. Using research findings as guidelines can improve nurses' awareness of new or better ways to practice, allow for documentation of nurse interventions, and improve outcomes at all levels of public health nursing practice.
We want to provide that best care that we can for our clients. We want to use be timely. We don't want it to be the process where we can only see one patient. We want to make sure that we're making good use of resources. That if the procedure says it calls for this, that we're having to use a huge number of. I guess I had an empty slide there too. A large number of supplies. So just making sure that we're fine-tuning our process and that it is the best. And if not, we just need to refine it. Okay, and this brings us to our last chapter here, nursing practice at the local, state, and national levels. So nurses either individually or through groups, we talked about professional organizations, can influence policy and legislation. So I don't know if any of you all have been to your nurses' day on the Hill. That's where they go and speak and talk to the governors, the politicians, the policymakers. And so, yes, and once you join and if you already might know this, if you've already joined your professional organization, where most of them have the health policy committee. You could be on that committee. On that committee, you will actually be looking at the bills that are actively on the floor. And then they do have tasks for you, like to contact whoever that politician is. Sometimes they'll have days where you can actually come in and speak. And so, because who knows best? Us, because we're right there. We're the ones that are in the trenches. And so with this being done, we can mobilize neighborhoods and communities, coalitions and networks so that we can provide the best care for our patients. This might include re-educating healthcare providers. It was an example that came to mind. It was with the diabetic patients, and it was just re-educating. We were seeing a high number of amputations. And so, yeah, they were going to the doctor, but their regular healthcare provider, they were not following through with the podiatrist. So it meant just re-educating the healthcare provider to mention, hey, let's go ahead and make that appointment before you leave. And so that you can have that additional set of eyes on your feet. And so with that being said, that did help. The number of amputations and things and wounds actually went down. The patients were like, well, hey, we knew that, but we really, how something, but then you don't really think about it because it wasn't what was being discussed at that time. All right, let's see. I'm going to try to play one of these short videos. Any questions about anything that we have covered thus far? Yeah, that's that Liberty Mutual commercial. Can you all hear the video? Are you all able to hear the video? Are you all able to hear the video?
We'll be chatting about
no. Yes. No. Okay. Okay, what I can do is just share the links with you. We'll just move on. There were, uh-oh, let me pause it. I'll just share those links with you, but we'll go over. There'll be two of them. They're just short videos for you to look at, just to kind of reinforce what we said thus far. Okay. Are there any questions? A lot of content, but we made it through all of it. So for those of you, make sure that you do the practice exam for the third time prior to coming to class. You all make sure you download the exam. They're usually open at least a couple of hours prior to exam time. In the event that you just got accommodations, make sure you turn that in to your campus deans so that that those accommodations can be provided for you. So we have just a few minutes here. I'm just going to toggle back. What was an example of active partnership with the community? What would be an example of active partnering with the community? What is an example of data generation? We talked about these things tonight. When we're generating data, remember we're out talking to the patient, the community members, and from that data generation, do we identify what social norms are, or do we identify like the racial makeup of that place, that community? Which one of those is data generation?
That would
Identify
be,
go ahead.
wouldn't that be like the value, the social norms for
Exactly.
that one?
Yeah. That's what we're generating that data. The other one, we're gathering that the just the information that a census would have, that will just be data gathering, from a map and all those things. So let's see here. What about let's do primary prevention for we see that there needs to be a change. The day on we went to the nurses day on the Hill, and we were given the opportunity to talk to the legislators. And we were talking to them about a bill that affected anything. We'll just say finances, affected someone receiving care if they had a certain disease process. But we were talking to the legislators, and we wanted them to pass a bill, or at least create a bill to address something. What level of prevention is that?
Would it be because you're addressing something that already happened?
So
Primary.
yes, it's primary because we want these bills to be passed so that it will not happen. So so that's still educating, but we're having a conversation with the legislator to pass a bill to help something, to prevent something from happening. So yeah, that's primary. Okay, let's see. So it's still that education, but it's in a different format, so to speak. Who most would we talked about early on? Who would most likely mm, be at risk for violence or even homicide happening to them? Someone that previously had something to happen, or someone that has never had anything to happen to them? Who would be at greater risk?
Child.
Someone who's had something previously happen to them.
Yes, whether or not it's a child or adult, yeah, but the thing is that they previously had something that happened to them. And so for physical abuse, remember we would see skulls, broken bones, bruises, and even injuries to the skin that resemble common things. Like, one time there was it appeared to be fork marks, like someone had heated up a fork and actually placed them. So things like that are indications or signs and symptoms of abuse. Like fractures, numerous of them, scalds, burns. Not to say that it is, but we want to definitely look into those things. All right, and so we are down to our break time. I'll stick around if anyone needs to talk about anything, but otherwise, you're free to go. We'll see you on next week. The harm reduction model is a public health approach, and it recognizes addiction is a health problem. Any drug can be abused. Accurate information can help people make responsible decisions about drug use. So that the harm reduction model is an approach to address. It has been found um, most valuable, most effective approach to drug addiction. When completing a community assessment, as we mentioned earlier, the nurse will need to include community system categories that are found within that community. So that's going to include everything about that community, the religion, the economics, the recreation, how they have fun, how they play, the education, the politics. We need to know all about all those things about the community if we're doing a community assessment. When we're conducting a windshield survey, it's a method that used to collect data about the community by observing the community. We're in a car or, we're riding through. So this helps the nurse to understand the community boundaries and also the actual boundaries of that community. And that windshield survey ensures that community is actually adequately observed, because we're gathering as much information as we can about the community, because we're coming back to do a community project to bring resources to the community. So we need to know about that community boundaries. So when we're talking about disasters, there can be man-made disasters. That's where um, bioterrorism can take place. So smallpox is one that we often discuss, and it can be prevented. So in the event that we have patients coming in and they have, distinct signs and symptoms, we can think of, you know, try to determine whether or not they have been exposed to smallpox. And in the event that they have been, we would expect to be administering smallpox, actual vaccines. And so a lot of times people don't have reactions after getting a vaccination, but in the event that they do, we do want them to, at that injection site, apply a cold pack. That does help for that first 24 hours, followed by a warm pack. But initially, we want them to apply that cold pack to that injection site. And we know we do have them to wait around and just to make sure they're not having a reaction to the actual vaccine either. Effective outbreak control requires first collecting data to identify the patterns of the disease, followed by identifying affected and at-risk populations. Interventions such as vaccinations and infection control are then implemented to reduce or decrease the transmission, and evaluation determines whether these measures are effective. Okay, so first of all, we have to identify the pattern. Followed by identifying the affected and the at-risk population. And then what are we going to implement to decrease the transmission? And then, of course, we have to come back and evaluate it. So think about the nursing process. So the National Research Act established the National Commission of Protection on Human Subjects as outlined ethical principles that are followed. The ethical principles of respect for persons focuses on obtaining that informed consent. And so we want to make sure that we are minimizing the risk when we are doing research projects. We want to make sure we have permission, that the patient has been informed of, the risks, alternatives. And this is the ethical principle of beneficence. We want to minimize that risk while maximizing the actual benefit. Ethical practice requires equity, treating everyone the same, being respectful, and advocating for the patient's, best care to be provided.